صباح الخير. هتكلم النهارده عن an update of sudden sensorineural hearing loss. Helen Keller, the famous American writer, once said that blindness separates us from objects, but deafness separates us from people. We have to differentiate between these two modalities, sensorineural hearing loss and sudden sensorineural hearing loss, and idiopathic sudden sensorineural hearing loss. Sensorineural hearing loss means defective auditory perception caused by damage to or malfunction of the cochlea and or cochlear nerve. The sudden sensorineural hearing loss is defined as hearing loss of sensorineural origin greater than 30 dBs in 3 contiguous frequencies that occurs in less than 3 days. The idiopathic sensorineural hearing loss, that's sudden sensorineural hearing loss with no identifiable cause despite adequate investigations. I'll give you some statistics. Most studies find no seasonal, geographic, ethnic, racial, or sexual predilection of sensorineural hearing loss. The right and left ears appear equally vulnerable. Reported overall incidence of sudden hearing loss ranges from 5 to 20 cases per 100,000 persons. Bilateral sudden sensorineural hearing loss is very rare, 1 to 2% of patients, and bilateral simultaneous sudden sensorineural hearing loss is extremely rare. In my practical life, I have seen maybe just one case. All age groups can be affected by sudden hearing loss, but fewer cases are reported in children and the elderly. The median age at presentation ranges from 40 to 54 years. Only 2% of all patients with sudden sensorineural hearing loss will have the cause of their sudden hearing loss definitely identified. In the rest, that's 90%, hearing loss is diagnosed as idiopathic sudden sensorineural hearing loss. Pathophysiology. There are 4 theoretical pathways that have been postulated, either viral infection, or could be vascular compromise, and it could be window membrane rupture, and it could be inner ear etiology. Any disease of these 4 theories could have sudden hearing loss as a symptom, and it can explain a fraction of the episodes of sudden hearing loss, but none of them can individually account for all the episodes. Known etiologies of sudden hearing loss. It could be infective, viral, mumps, measles, cytomegalovirus, varicella zoster, could be bacterial, meningitis or syphilis, vascular, a lot of pathology, thrombosis, emboli, spasm, Berger's disease, leukemia, sickle cell disease, polycythemia. Could be neoplastic, schwannoma or temporal bone metastasis, carcinomatosis, meningitis. Could be toxic, aminoglycosides or cisplatin. And finally, it could be traumatic temporal bone fracture, acoustic trauma, a penetrating temporal bone injuries, and could be autoimmune, Cogan's syndrome, multiple sclerosis, Meniere's, sarcoidosis, Wegener granulomatosis. All of these known etiologies should be considered and ruled out before the most common diagnosis, idiopathic, sudden, sensorineural hearing loss, is accepted. Presentations. Most patients report onset of hearing loss either abruptly, may be demarcated by a pop in the ear. See, I heard a pop or explosion or something like that. Or within minutes to several hours, and about 1/3 of patients will awaken with the loss. Others may discover the problem when they try to use the phone, or may describe a brief period of fluctuation before the loss becomes stationary or progressive. Prognosis. It is generally agreed that spontaneous recovery is common in sudden sensorineural hearing loss, usually occurring within the first 2 weeks of onset. Matrix and Simmons stated that 65% of all sensorineural hearing loss patients will have spontaneous recovery with no medication at all of functional hearing without treatment. Prognosis. Patients with isolated mid-frequency losses recovered without regard to therapy, usually recovered spontaneously, mid-frequency. 76% of patients with losses greater than 90% dB fail to recover regardless of therapy. Very bad prognosis if it is more than 90% dB loss. In patients with hearing loss less than 90 dBs, not limited to the mid-frequencies, 78% treated with steroids improved compared to 38% of untreated patients. This table shows very well the prognosis of sudden sensorineural hearing loss. The prognosis is usually good in mild or moderate loss. It is bad if the initial loss is severe. It is bad if you start the treatment late. It is bad if there is concomitant vertigo, and it is bad if the shape of the initial audiogram is sloping. It is good in mid-frequency loss, as we have just said. It is bad across many or all frequencies. It is usually bad if under 15 or over 60, better in middle age. And it is good if ESR is normal, bad if the sedimentation rate is raised. These investigations are suggested in literature. I'm not suggesting them, by the way. All sorts of investigations: hematologic, radiologic, CT, MRI, audiologic test batteries, vestibular assessment. And all these treatment modalities are suggested in the literature, and I'm not suggesting them, by the way. Medical treatment, no treatment, vitamins, vasodilators, oxygenators, corticosteroids, anticoagulants, antivirals, hyperbaric oxygen, anxiolytics, bed rest, others. I'm sure many of you are using these types of treatments. And even there is surgical treatment supposed by some exploration, corticosteroid injection, stellate ganglion block. Now we are going to the American Academy of Otolaryngology Head and Neck Surgery, the clinical practice guidelines of sudden hearing loss. This is the update, the most recent update, August 2019. What is clinical practice guidelines, by the way? Clinical practice guidelines, by definition, these are recommendations for clinicians about the care of patients with specific conditions. They should be based upon the best available research evidence and practice experience. The objectives of clinical practice guidelines to improve diagnostic accuracy, to promote early diagnosis and prompt intervention, to decrease variations in management between clinicians, reduce unnecessary tests and imaging modalities, and improve hearing and rehabilitative outcomes for impacted patients. In these guidelines, we are talking about policy levels. And this is policy number 1, recommendation. Means it is wiser to be followed, and I will put it as a orange logo, okay? Strong recommendation, I put it as a red logo, means this recommendation should be followed. Option. Option means it can be followed, it cannot be. I'll put it as yellow option. And lastly, no recommendation. Yeah, this no rational evidence to support this recommendation. So it is better not to be followed. Okay, now I will tell you the clinical practice guidelines of the American Academy of Otolaryngology about sudden hearing loss. This is a summary. We start by presentation. Sensorineural hearing loss should be differentiated from conductive hearing loss. Strong recommendation, goes without saying, yeah. Patients with suspected sudden sensorineural hearing loss should undergo history and physical examination of bilateral sensorineural hearing loss, recurrent sensorineural hearing loss, and or focal neurologic findings. This is a recommendation. Patients with presumptive sensorineural hearing loss should not undergo routine head CT scanning. Don't do CT. This is a strong recommendation. Audiometry should be performed as soon as possible to confirm the diagnosis of sensorineural hearing loss within 14 days of symptom onset. This is a good or strong recommendation. It is a recommendation, better to be followed. Routine laboratory tests should not be performed in the workup of sensorineural hearing loss. This is a strong recommendation. Don't do all these lab tests. They are useless. Patients with sensorineural hearing loss should undergo MRI or auditory brainstem response to evaluate for retrocochlear pathology. This is a recommendation. By the way, this is not my sayings. This is the recommendations by the guidelines of the American Academy of Otolaryngology. Patient education. Patients with sensorineural hearing loss should be educated regarding the conditions, natural history, and the potential benefits and risks of treatment. You have to educate your patients. Treatments. Corticosteroids may be offered to patients with sensorineural hearing loss as initial therapy within 2 weeks of onset. This is an option. You can use it. You don't use it if you don't like it. I use it, of course. I think it's the best. That's my experience. Patients with an incomplete recovery from sensorineural hearing loss should be offered intratympanic steroid therapy 2 to 6 weeks after symptoms onset. This is a recommendation. Treatment. Hyperbaric oxygen therapy in combination with steroid therapy may be offered to patients with sensorineural hearing loss within 2 weeks of onset. This is an option. I don't think it is very successful in my experience.
Time, Dr. Mokhtar.
And just 1 second. A hyperbaric oxygen in combination with steroid may be offered as salvage. Antiviral therapy, all these type of treatments, don't use it. No antiviral, no thrombolytic therapy, no vasodilator. All these are not helpful. Outcome assessment should be done after the conclusion of treatment, and rehabilitation. This strong recommendation. Sit with your patient and you rehabilitate maybe a hearing aid or cochlear implantation if necessary. This is the last slide. That's management therapy. If you have patient with sudden hearing loss, you have first to exclude conductive hearing loss. If you exclude, then you assess for modifying factors, bilateral, recurrent, focal neurologic examination. If you exclude these factors, then don't obtain routine CT. Don't do CT. Okay? And don't do routine lab. And then confirm sensorineural hearing loss with an audiogram. If conductive hearing loss out of our scope, if sensorineural, we assess for retrocochlear pathology by ABR or MRI. I think MRI is better. ABR is not that good. If there is no, you have to educate the patients about the possibilities. Don't give antibiotics, by the way. If the patient within 2 weeks of onset of hearing is not recovered, you may offer corticosteroids or hyperbaric oxygen and reassess of hearing within 2 to 6 weeks of onset. If he does not recover, you have to see the outcome assessment and educate your patients. Thank you very much.
Thank you, Dr. Mokhtar. We already ahead of our time, so the questions are at the end. Thank you, please. Now, Dr. Mounira will talk about sensorineural hearing loss. Is she here? I think she
Dr. Mounira is not here.
She was in the parallel session. Someone told, I think she couldn't. Okay, now we are moved to questions. Is there any question for Dr. Mokhtar?
I have one question, Dr. Mokhtar. I read about a new drug called AM112 for treatment of sudden sensorineural hearing loss.
Haven't heard it.
We don't know. I want to know what this drug and what.
I don't know myself. What is the drug? What's يعني فصلته ايه في الأدوية؟
Chemical drug used to treat sudden sensorineural hearing loss. It's under research. And some papers say it has benefit.
And I haven't used it.
Okay.
I haven't heard it.
It's not present in Egypt, I know.
Yeah.
But I ask if you read anything about this or.
So I'll tell you, if you get some patient with sudden sensorineural hearing loss, number one line of treatment is corticosteroids. You either give it by systemic route, or you can give it by intratympanic. Sometimes the patient has got, he's diabetic, he's hypertensive, he has got peptic ulcer, he has some other systemic disease, and you cannot give systemic corticosteroids, so it's better to inject or do intratympanic injection. For intratympanic injection, you have a choice of two. Either you inject through the tympanic membrane by a very fine needle, a dental needle, for example, and I do it in my office under no anesthesia. It is, I'm telling you, it is very bearable. It is very tolerable. It does not need any anesthesia, not even local anesthesia. And you do it twice weekly for 2 to 3 weeks. Or you can self-administered corticosteroid. You just do a grommet tube. You insert it in the posterior inferior quadrant of the tympanic membrane, just against the round window. And the patient will instill eardrops, corticosteroids, dexamethasone in his ear while he is lying on his side. 5 to 6 drops, so that it covers completely the medial part of the external ear and your grommet that have you just inserted. And then you instruct the patients to do Toynbee maneuver. Toynbee maneuver, the patient closes his nostrils and swallow. When he does that, he will create negative pressure in the middle ear that will suck all the fluid in the external ear into the middle ear. And then corticosteroid will go into the inner ear. And you know, this is local therapy with corticosteroids. And when this happens, I know you can give it systemic and give it local by injection. For example, the concentration of corticosteroid in the inner ear is something like 300 times more by intratympanic injection in case of hydrocortisone, and 700 times concentration more in the inner ear in case of prednisolone. So the patient, he has got his grommet. He can do as much as he can. I advise 1 time instilled drops in his ear per day for 2 weeks or something, and I think this is the best. I have no faith in of hyperbaric oxygen. That's my experience. Okay, that's any other questions? Fatih?
شكرا.
Thanks, Mokhtar, for this nice presentation. There is a German school where they explore for perilymphatic fistula in sudden sensorineural hearing loss, and they report relatively good results. Are you aware about that? Have you any experience with that?
Yeah, okay. I've said one of the treatments is surgical exploration, and this is reserved for if you are afraid of round membrane rupture, perilymphatic fistula. I tell you, I was trained in Minnesota with Professor Michael Paparella. He's my boss, and he does an exploration for every sudden hearing loss. And I am with him. He has never once found a round window rupture because you don't see fluid coming out. He said, hey, maybe this round window, and he just closes the round window niche with fat or something, but I don't think. So I don't agree for that. You know that this spontaneous recovery, Fatih, so you won't be able to compare.
Thanks to Dr. Mokhtar. We end the round now. Thank you.
Thank you very much.